Annie, I think you're on the full screen.
Everybody on Teams, if you've just joined recently, I think they're still at lunch right now and we'll be coming back on in a couple minutes.
Thank you.
Uh-huh.
Sarah Dearborn, do you know where we can get the slides?
I'm pretty sure they'll send them out after. They have been posting information on our DHCFP webpage, the behavioral health webpage. So they may also post them there, but I'm hoping they'll post them after.
Okay, thank you.
Uh-huh.
Paul and Allie assigned to the there's a way to. Oh, you could do assign, yes, manually. I've never done this before. Oh, okay. And then you just go through and do 1, 2, 1, 2, all like that. Allie, let's see. No, that's not her. Oh, I don't know what Allie is. I can see her on the screen though. Does it show Paul? Oh, I see. I think that's right. Yeah,
Should I just try to do it the other way?
Try searching on Allie. Can I go back to that? Oh, we're trying to figure out how to do the breakdown.
Are you able to do the room on your text all
How many are you showing in the meeting?
Why don't we just tell people to join maybe group A1 or B, A or B? Just do it that way. Call them out and tell them you're in A.
Oh yeah, no, that's right. 45. Oh, it only allows you to do 15 at a time.
Is it 45 including people in this room?
No, maybe it's included people in this room. But I think it would just be this one connection.
Let me try to maybe just add them and then the rest will pop up.
Try it, yeah. And then you have to select for each one of them. See where it says unassigned. Click on that little arrow to the right. Oh, there you go. Right, and then click on room 2. Wait, hang on, that's the first room. Hit cancel. And then go to room 2. Click on room 2.
No, this is there's no more.
Yeah, but go ahead and click on that one.
It doesn't open.
Oh.
When the legislature was here.
Okay.
has to be.
Oh, you directly to that.
Go to the three dots on the side and see if it works. Don't do it on the. Your team's likes to work with the dots. Right? You went here. Go to the three dots. Can you go to open? All participants have been.
Maybe it has a 15 participant limitation, in which case this is just. Okay, hit the plus in there.
Hit that.
Oh yeah, that gives you another.
See if you can ask what it's showing.
I think it only.
Okay, assign the remaining.
I think we already assigned these are all to one.
Yeah.
Can we do Zoom? I have my Zoom account. We just have to send out a new.
Yeah, then we
Or let them stay and
maybe, yeah, maybe just with the left. I don't think it's gonna work.
we're in official. We're in official. Don't break out.
Maybe just
Do
one.
one.
Let's do one at a time.
Together. Yeah, one at a
Okay.
time.
All right.
And tell Colin now to release it.
Okay.
So there's no working out. Okay, we're gonna, we had a little bit of technical issues, so we're gonna try and do a little bit of a reset. We were gonna do breakout groups, we're just all gonna stay together. And we're gonna do the two cases in sequence, so. And the folks on the team will see us as an official.
I'm gonna switch to virtual. My son has medical.
You gonna take him at the airport, Anna?
I have to pick my we'll take him to the airport.
I forget what it is like, my kids are older now, they drive. You drive to the airport, I hope you have hands free.
Yeah, the dentist called while I was here. It's like, you really did something.
What's that?
What do you think?
We're just gonna not do the breakout, so just go ahead and cancel the breakout. And then share the screen.
Are you here?
Oh, okay.
I live down here.
She's gonna be in Reno. Stacy and I are
Oh,
gonna
yeah.
have drinks.
You're gonna be in Reno. I'll be there.
You coming to CGC?
All week. I'm coming tonight, like after the dentist, I'm going to the airport to go to Reno.
What time's your
And then,
flight?
let's see, can you just go to the next
I'm
slide?
at a 9 o'clock flight.
There's a dentist. Yeah. So I'll be there tonight either.
And
I think tomorrow night you should go. You should come to us too.
Yeah. I'm in Carson.
Oh,
I'll be done with the Okay.
Okay,
We figured out?
all right, change of plans. So we were gonna do breakouts. That's not gonna work on Teams, so it's not really gonna work for everybody. So instead, we'll still do the vignettes, but we'll walk through them as a big group rather than doing breakouts. And so we'll start with one that is delivery system options and benefits support for a high intensity case. We'll start with that one, and then we'll move on to the second one, which is kind of not a high intensity, I don't know, low to moderate, however you want to describe it. And the idea is that we will look at these vignettes and talk about how things would work in Nevada today for these individuals, these children, and then talk through a little bit how we think it could work better, kind of with thinking about either the things that we talked about earlier today, that we presented earlier today, or your own knowledge about other systems and how they work in different states, or based on your own experience or knowledge. So let's go to the next slide. Okay, and this is the first one. I will read it out because it's kind of tiny and hard to see. So Luke is a 15-year-old male who likes to read, draw, and listen to music. His interest in reading usually entails science fiction, but he rarely has access to books, and he does not have a smartphone to access reading materials he enjoys. He likes to draw characters from other planets using his imagination to draw what they look like, but infrequently has access to materials to draw in colored pencils. Luke is living with his grandmother temporarily, while his mother is in substance abuse residential treatment. The last time this happened, Luke ran away after being with his grandmother for 3 weeks. He does not like the apartment. Luke has not seen his father for 3 years. The last time Luke visited his dad in prison. His dad will likely be leaving the prison in 1 year. He has a boyfriend, Elijah. He has only told his family they are friends. He likes Elijah's sense of humor and ability to talk about hard things in life. Luke has received behavioral health care in the past, but has not received care due to moving so many times with his mother. He received care for cutting on his legs that no one saw for a long time. He shared with Elijah that the reason he cut on himself is that the kids at school made fun of him for being quiet and not knowing how to interact with others. After his second day in the new school that his grandmother took him to, the teacher noticed how withdrawn Luke was, did not interact with others, and saw him using a paper clip to scratch his legs. This is kind of point of entry, right? The teacher has noticed this, is working through school systems of care, is making whatever referrals it's going to make. How would this situation, how have you seen similar, or based on your experience, how would this situation play out in, in a Nevada system of care today? And folks on the Zoom meeting, if you could just come off mute and weigh in. I know you've been using the chat, and that is great. But if you want to speak up, please feel free to do so. So who has experience with a case like this?
I mean, we
So can I
sometimes,
ask, so are you asking what this would look like in Nevada's system of care as we have it now?
Yes.
How would the child enter the system? Who would serve him? What is likely to happen? Just walk through a grandmother in Luke's shoes. What do you think would happen to this boy, this young boy in Nevada?
Kind of insurance.
Let's assume he has Medicaid, right?
I think it would depend on where the parent was and their understanding of the school reached out to the parent, what the school contact, who was aware of community resources. They might contact the harbor here, I'm thinking, because it's a site for teenagers who have some challenges, and those harbors are located in different communities here in Las Vegas. So I'm wondering if the parent would take the child there, or would the school possibly refer the child.
So this referral would start from the school, right?
Yeah, my hope would be that the teacher would call grammar and start there and find out the child's history and see where he's been, what he's done in the past. Is it normal for him to be quiet? What's his history? And then obviously find out where he's already been and what's worked, what hasn't worked, and then determine where that should go. Does he need to be assessed? If he's had other issues in the past.
Would the school be picking that up, or would they?
Well, there's a combination, because if you look at the educational component, and you can say this more than I can, we can do an assessment to find out if educationally he's at standards and what he needs there and what supports he might need. whether that's a 504, whatever that looks like. You may not need that, you may need more of just behavioral health, but obviously, so I think it's a combination of resources. Again, like I was saying earlier, you wrap that child with school and whatever resources they have, and then any external resources that they need.
If there's someone in the school that the teacher reach out to, the teacher was, we got so many teachers, and they don't know, and this is not, they don't know their main job, so I don't know if they need to be secondary. That's what I'm saying. Who would be in the school to help?
They have psychologists,
More
counselors.
It's really hard right now because every school is on strike. Even here in CCC, we have some elementary schools right now without school counselor, without a social. So it's kind of if that, but let's just take best case scenario, that it's a school that's practicing multi-tier system of support, there's a social worker, usually the referral pathways would be the teacher would bring a concern to the social worker, who might speak to the student first, talk to parents, and then really start to see, if it's social, if you're going to child from social isolation, work on a very low level of social emotional learning and how to, get better, more social connections. Schools do that really well with that tier 1. And if, if the child, they may also do a screening. And so if that child, internalized or hot, there could be some referrals after that. But most schools, if the system is working on, and if they have a social worker and school counselor, they have those multi-tiered systems of support, and they always try to start with the least. Yeah, just kind of, how can we help you make some new friends here? I mean, going to a new school in high school is pretty traumatic. So, and then add on.
Hi, I'm sorry to jump in and interrupt, but for those of us on Zoom and for those of you in the room, we're picking up a lot of the background noise. And so I don't know if it's possible to maybe, if you are speaking, since this is so important, to just maybe like lean into the microphone so that we really pick up on your audio so we can kind of hear what the discussion's happening.
I think it's just, we'll probably just have to shout a little bit.
I think it's wired in the room. I think the mics are wired.
It's fine, whatever helps, just so that it's a little clearer for us on the call.
Yeah, and I'll try and keep an eye on the, whatever the transcription is, so that, and call it out if we need to shout. I'll be the shout police. I'm sorry in advance.
This is Karen from Nevada PEP, and I'd just like to say that sounds great, what I heard previously, what I heard of it. However, that's not the experience of the families that contact Nevada PEP for help. So I think, like Nevada has always been, there's pockets of excellence everywhere, and then it's not brought to scale. So that that probably does not, well, I know it doesn't happen to the families that contact us.
So Karen, what would a, outside of a pocket of excellence experience be like?
I think for a while it would be ignored, that it would go on for some time, so they wouldn't catch it like the second day of school, I think that said. And there might be a call to the grandmother, but it would have to escalate past that to really get much attention.
I hear you saying that there's an access or maybe an issue with identification, maybe at the teacher level of like when a referral might be necessary to the school counselor. Maybe that would be the delay there.
Maybe that's where the delay is. Yeah.
On that note, I have a question. It says on the thing, the breakout, that this is the high intensity. Does that mean there's a high intensity
need of the child, or like we should be thinking about what would a high intensity service look like?
No, so we keep escalating this, right? Like, so he comes to school, he's had some past history of suicidal ideation cutting, right? Now, he's been observed doing cutting behavior now. So let's escalate this a little bit more so that he actually, the counselor approaches him. Let's assume things are working the way they're supposed to, right? The counselor reaches out to him, pulls the grandmother in, and then he expresses suicidal ideation. He says, I'm feeling really hopeless, my mother is in treatment, my father's in jail, I'm tired of moving around, nobody loves me, nobody cares about me, blah, blah, blah. Things are escalating, and the school says, you know, if he's got suicidal ideation, the school's not gonna let him come back until he's more stable. And so the school says, we need, and you know, nobody over here is talking about whether grandma has received any support. Is she raising this child on her own? Are there any financial support she's getting? Anything else going on? Was he placed with her as a kinship? Like those are not. So you build this, the whole idea of this case was to give you, and for you to take it any avenue you wanted, to keep building it out, to sort of tease out what works and what doesn't work about it. So keep adding components, elements to the case that will help you take it into all the different systems that it needs to go, right? We've just started, we're just giving you the base.
I think I agree with the individual who was on the Zoom talking about, you know, they're coming to Nevada Tech, and unfortunately, there are pockets of really good social workers in schools, and then there's people who don't have the social workers and have the resources available. So when you're in a school that doesn't have someone who's highly focused or well trained in the social aspect, you end up with children who are receiving a resource pamphlet and a call home. And then they're taking their little pamphlet home to grandma or whatever, if it ever gets off their backpack or makes it in their backpack to take it home. And unfortunately, that's where you have your first roadblock to be able to get the child the proper services they need. And so it would be really great if there were other, not just resources, but trainings made available to maybe schools that don't have a social worker at hand, or being able to have a partnership with the most local schools to be able to assist. But I know even just working like with other children in the community, like in my church, you know, things of that nature, that's where the roadblock begins. And then unless they have other supports in their little village and people around them that they're able to fill in the gaps and be able to get the information that they need. So if there was some way to fill in that gap to be able to get it to the next level, that would be remarkable within itself.
I mean, as a child welfare DA, and not to go too negative or high intensity too fast, but this is a scenario where one of the things that I start to worry about is the entry of a child into the child welfare system, not because of primary abuse neglect, but because of inability to meet their mental health needs. And so we see stories, I think, that start like this all the time, and it's kind of a flood, it was a trickle, and now it's a torrent of families where it's a situation like this, a child who needs to be able to access help outside the child welfare system, grandma can't for whatever reason. Then they come into child welfare under the assumption that there's more resources in child welfare, and that's a struggle in and of itself. And also then you have all the implications for a child and family that come with coming into foster care that are damaged.
So let's take it 2 steps at a time. Let's take the first one. What are the services in the community that could have been mobilized, should have been mobilized to help stabilize, right? Like let's do the upstream. I know this was intended as a different vignette, but since we're all staying together, we can gradually escalate you, right? So the first is, these are the presenting issues for Lou. The school's raising a flag. Grandma is very supportive, is more than willing to meet his needs, right? So what do you think needs to happen to stabilize him so he doesn't come into the child welfare system, right? But is getting the supports that he needs, and grandma's getting the supports that she needs. So what should happen first? Let's do that, and then we'll make Luke sicker. And those, our grandma says, you know what, I can't, I have another grandchild I'm taking care of who's, 6 years old, and Luke's, doing something there. And so.
So firstly, I think they need to engage in high fidelity wraparound services. That would be where I would lean in first.
Who triggers that, and how does that happen?
Well, should I call out how bad my program is right now in front of everybody? Wraparound services.
Trust Street.
No surprise, right? In a theoretical perfect world, their school would perhaps refer them to one of my non-existent wraparound workers who would then help coordinate and wrap services. But good news, we got $14 million to stand up wrap services. So, but I would lean in firstly to wrap all of the stakeholders engaged in this process with wraparound services.
I think too, more likely, he was presenting with suicidal ideation. Again, there's so many ifs, right? But so this is best case scenario. I think the schools would probably call local crisis. They get a stabilization plan. And ideally, that stabilization plan would be shared with the schools to help make sure that Luke stayed in school.
I think the hardest challenge for those of us in the community is you may know that there's a program, but it's capacity to manage is where the question comes in. And probably that's what they need to say Harvard, because it's the only thing I know that is standing that has people there. So I don't know that I would not say it's the best place, but I could see it being a place of community thought.
And the schools use the Harbor a lot.
Because they don't have
Yes,
those
a
other
social
things.
worker or
Right.
social counselor.
Right.
What is Harbor?
It's a juvenile assessment center, so modeled off of some places in Colorado. It's a joint partnership of state, so state child mental health is there, juvenile justice services, child welfare agency, and then it's also contracted out with one of our local providers, Eagle Quest, who provides foster care services in town. So it's the concept is it's a one-stop shop for assessments, and then the original concept was the services were supposed to be occurring in-house, but what they do now is they refer them out. So it's one place that a family can go to obtain an assessment, and then the services are referred from there.
It's statewide.
It's only in Clark County.
So assuming he's in Clark, then they make the referral to the harbor.
Right.
And then what happens there?
So as well, so first you have to assume grandma doesn't know how to access any services or what she needs, because you don't know if she has any supports based upon that vignette. And then you have to assume if he's in Clark and the school recognizes that he has a need for interventions, that they're consistent across the 5th largest school district in the country, that each school is going to know to refer to the harbor if they do not have a in-house counselor or social worker. So you have to assume that every school is being consistent. So ideally, they would refer the grandmother to the harbor. The grandmother would make an appointment and take the child. The grandmother would be assessed, a part of the assessment, I should say, for a historical background. And then the child would be assessed, and then they would make a list of services that they could offer in the community and refer out. And then the harbor, the last I heard was case managing for about 6 months. So they're supposed to be continuing to follow the family to make sure that they're engaging in the services and that they're receiving the services.
But do they do a warm handoff, or do they just say, here's a list of services you can go get?
It's supposed to be a warm handoff, but I do not know. I think the program's grown really big, and we were just talking about this. I was one of the founding mothers of the program, but it's gotten really big, and I just personally have a hard time believing that they can find services if we can't find services. So I'm not sure that they have like this hidden service place that they can only refer to, because child welfare can't find the services, so. It's supposed to be a warm handoff. We have plenty of people on the Zoom call, maybe somebody's had some recent experience with them.
This is Karen. I want to say that we get direct referrals from the harbor, and that we commit to returning those calls and serving those families.
And Karen, this is Bridget. Hi, Karen. You do it for the adult care provider, right? For Nevada PEP?
Yes, we help
Not the child
the
services, but you're helping grandma in this scenario.
we're helping grandma in this scenario, yes.
What does that look like? What would you do?
We would talk with grandma about what she thought her needs were and help her figure out what services she thinks would be supportive to her and her grandson and help her navigate to those services.
And are you mostly able to get grandma connected to service?
Well, we're experiencing the same thing as everybody else, and there's wait lists and things, but the importance of the peer support is grandma has somebody to talk to who understands, and that she can get out what her frustrations are in a non-judgmental fashion. And sometimes it's just the listening that makes the difference for grandma.
Who works with Luke then? We're working with grandma. Pep is working with
So
grandma.
Luke could be referred to any number of local services in the community for counseling.
So they would be served separately, not together.
There are options to be serviced together in like any type of family counseling, but that would require, that being assessed as a need for family counseling.
And I'm curious though, in my mind, I think of the harbor when kids are having behavioral issues. I think of it with the JJ connection. So I don't know how the school thinks of it. So if this child were acting out and causing trouble on campus, school might think of referring him to the harbor. If he's just acting withdrawn, is the school going to think to refer him to the harbor?
Well, that's why I said that we need to know how the school's trained consistently across the board to use it. It is actually, I think it's more used for kids that aren't JJ involved than it is for kids that are, JJ being juvenile justice involved, than it is for kids that are juvenile justice involved. School referrals are our #1 resource, but how they train the schools to identify which kids to go, I'm not sure.
But the schools are really frustrated right now, and so they'll try any law. So if the harbor, even though they probably know for diversion, but they'll try it, if somebody answers the line on the other side, they'll send it. But I think we have some people on the call from the school systems that are actually.
Yeah, that's what I was wondering, if there's anybody that could, yeah.
Is there anybody from schools on the Teams call?
Can I say something? I'm in Washoe County. So I just was sitting on a social work panel where one of the other social workers in my group at UNR works at Wooster High School as one of the social workers there. And she was saying that one of her frustrations in understanding the level of care that kids have with suicide ideation and parasuicidal behaviors is that she knows, and at least in Washoe County, that kiddos that have Medicaid, not as many providers accept Medicaid. And so the wait list can sometimes be, or most of the time is around 90 days. And so then by that time, some of this SI has escalated and then they need to be referred to a higher level of care. So there's also some barriers to not having enough providers that accept Medicaid at the school level, right? So like, or the school counselors are not aware of those, who the providers are.
So this is gonna play out different even in Washoe, let alone rural.
Hi, this is Michelle Sandoval. That's what I was going to follow up on. In our rural areas, what this might look like is mobile crisis being called in, working with the safe school professionals or school social workers, because mobile crisis in the rural areas is seen as kind of an entry point, an access point for youth and families. So that might be a starting point in our rural areas.
And then what would happen, Sandy? Let's say mobile crisis response, then what happens?
Depending on what the family's needs are, kind of like Karen said with PEP, we're just working with the family to see what we need, how we can help, stabilize, safety plan if needed. And then we do follow up, and we have case management that then helps connect that youth and family to whatever services they identify, usually in their home community. And because we're in the rural areas, we know the rural resources and can help get them connected. So. And then we make sure that it's a warm handoff, that they're satisfied, comfortable, happy with the resources that they have, feel like the healing process has begun.
Do you have provider shortfalls or waiting lists there? Or it works well for the most part?
We do. There is definitely provider shortage in the rural areas. We do a lot of telehealth when the family thinks that that's an option for them. But one of the good things with mobile crisis is our clinicians and our team can stay with that youth and family until they are connected to services. There's no time frame there. So even if it's a 2-month wait, that family is still being wrapped with services by a clinician and a case manager.
Now, you have large geographies to cover for your providers, right? Are they doing a lot of in-home work, or is the family bringing the child to a treatment facility?
I think it depends on
telehealth. Sorry, yeah.
Well, that's okay. Of course, it depends on the youth and families' needs, right? And what's going to work best for them. But one of the things we saw as an outcome of the acute COVID pandemic is we saw a lot more in-home and telehealth services being brought to the family's location of choice.
And are there capacity issues with the mobile crisis, or are they able to, if he were less severe, would they say, oh, you're okay, we have more intense cases to deal with, or is the capacity adequate for the mobile crisis?
Just specifically speaking for the rural areas, at this time, it's adequate. I think that, one of the things because we do see it as kind of that entry point, we're trying to do a handoff as soon as possible to the resources that the family needs. So right now, yeah, we're able to handle the numbers.
Okay, well, that's great. That's wonderful.
Yeah, and that's interesting too, because
that's the first
you
we're
might be
hearing.
better off being in a rural environment if you move than you would be in Washoe.
Yeah, our rurals are better staffed too in our schools. Fewer students though, right? Fewer students, right? The ratios are easier to meet in rural places.
That's good.
Yeah.
This is the first we've heard
Volunteer,
of sort of because up until now, we kept hearing how difficult the rural environment was in terms of presenting itself with services and resources. So that's not.
Well, it depends on what school. Let's not give her the wrong idea.
I was going to say, it doesn't look perfect, absolutely.
And was that from the perspective of the mobile crisis provider? Is that the same perspective of those community access?
Sandy, is that who you are, a mobile crisis provider?
So Michelle Sandoval, I manage the Rural Mobile Crisis Program. We do satisfaction surveys with families. We have at this point, I think 100% satisfaction rating from families. So I think we're doing an okay job. But again, like we're saying, this is just one service. We're doing what we can to get out there and help, right? The state has put this in place and provided funding because there was this gap. And so I think as we're building our crisis system in Nevada for youth and families, that, I think we're going to see some great other services come into place as well as mobile crisis. So, but we're definitely in the rural areas. We're short on providers. Of course we are. We're short on in-person providers. We're short on psychiatrists. We're just fortunate that we've kind of adapted and been able to really utilize the telehealth system.
One of the questions I have for those in the rules though is just how successful are we in engaging? Because I think if we can engage them, we probably can serve them. But as an early provider for adoption services, I found it extremely hard to engage that population. There's a reason why people move to a rural area. They don't want to be bothered. And so then here we come knocking on the door saying, we know you have this need and we want to help fill it, but there's no relationship there. It's not like a community program where people got to know who's going to provide the service. I'm talking about just by having somebody drive 100 miles to provide it. They don't know you, they don't know your community, and so it's not as received as well as that particular service that we provided, which was adoption support, wasn't received as well as we would have liked. And I think so much of it centered on the engagement piece.
Yeah, there's also a question here. If Luke doesn't have a phone, he doesn't have a smartphone, and there seems to be some technology interruptions in his life. Like, how would you deliver the therapy or the telebehavioral health visit? Would there be some challenges there?
Sure.
Well, then,
Sorry.
Well, I was going to ask, like, would then you maybe set them up with medical transport management to get to a rural to be able to provide in-person services then? I mean, I think the one step I missed, and I don't know if you guys said it in the room because I didn't hear it, but I mean, at what point are we assessing the level of suicidality and what kind of screening tools do we need to have in the schools for that?
And is it fair for school counselors to do that kind of in-depth assessment, right? Or is it a different kind of screening partnership to do the screening, right?
Should be screening first.
So I think back in the day, when we were contemplating like what would this service array look like, it would have been something like this happens, the teacher realizes, oh, there's a concern, you can call somebody like a mobile crisis, but maybe this isn't quite a crisis, but you can tell there's some need for services. We had intake coordinators with children's mental health. You would be able to call this intake coordinator and say, hey, here's what I got, here's the situation. That intake coordinator could then sort of act like this navigator that you're talking about and help grandma make sure that she's connected to everything that she needs to be connected to. But I don't think that we have that hub right now. And I think that's the piece that
In Clark or elsewhere.
I can speak confidently that Clark doesn't have it. I don't know about elsewhere.
I think a lot of the times too that on top of being a director, I also am an intake coordinator at the psychiatric hospital, so I see these cases all the time. And so the school counselor, what they'll do is they'll tell the parents to bring them down to the hospital. And so we'll assess them and see if they need that acute level of care, or also we would refer them to a therapist or medication management. So I think that's where the school counselor, instead of them trying to find, some services, we already have the services at the hospital. So we have to give them an appointment within a week of us seeing them. So they have to have an appointment with the therapist within a week.
I mean, I do think it makes more sense to have it be centralized somewhere like that, because then you're not relying on the school counselor to try and do this, and then you have all kinds of different school counselors and all kinds of different schools, and how do you ensure that consistency when you have so many steps that person needs to take? If it's getting sent to some sort of centralized hub that ensures like eligibility for services or coordination of care for services, that's only one step you have to get everybody consistent on making instead of multiple steps.
So let's let's make this a little bit more acute, right? Since the real issue is the lack of providers and the need to have MCOs allowed in towns. But let's, Luke didn't get service on time, right? Or Luke's school social worker sent him to the hospital. Either situation, or he didn't get the services and he escalates in the meantime. Which is, I think, when that was one of the things he said, like he escalates and he ends up in a more acute setting. What happens then? Grandma says, this is too much, I can't care for him right now. His dad isn't coming out for another year. Mom, in the meantime, has relapsed and left out without medical advice out of the treatment facility and is missing, which exacerbates his sense of crisis and loneliness.
It's on the child. They go to the ER, somebody calls us and says that parent is refusing to pick up the kid, then we get involved and we become a child welfare family.
On child welfare.
And every family forward to placement, when he gets to child haven and he escalates and he goes to the hospital, or maybe he gets in a fight at child haven and he gets sent to detention and then this horrible.
And would you find against grandma in this situation, even though it's not, she has really not either abused or neglected him? Would you still have
I mean, I can speak from my perspective, right? He has parents who have things that have prevented them from being able to care for the child. So to turn it into a court-involved child welfare case, there has to be an allegation of abuse or neglect. There has to be.
So there is no voluntary placement?
Not for court-involved.
There are programs and services and support families with children, right? But that means someone had to know that they existed and be able to get them there. That seems so specialized. I don't think that a lot of people know that medication care provider needs and what they do.
Well, we do have a statute that allows voluntary placement into the child welfare agency. We have no placements, so we don't often use that statute because we don't have anywhere to use this program.
But going to Valerie's point, I mean, I think if you rewind this whole scenario to the beginning, right, there's a whole bunch of different things. If when mom and dad became unavailable, grandma had some access to financial support or services, like we don't know what she got at that point. We were even talking, this kid may not even have gotten enrolled in school because grandma didn't have a guardianship and she didn't have a placement letter. And so they would have told her to go to the guardianship court and apply for guardianship. She'd never have gotten the service done. So that would have never happened. So we may not even have gotten this kid into school. So I think when we talk about getting upstream, those are the kind of things we have to be talking about to kind of troubleshoot.
If they're going to school because they consider determined, and that's how it's.
So is it staying in Washoe County, that like the welfare side of it, like the child welfare system, is the same kind of system for Washoe, or is it different?
I don't like to speak.
Oh, yeah.
Washoe, you out there? Yeah.
Are there Washoe child welfare folks on?
I think it's the same issues and
Same
just,
law.
yeah.
Yeah.
Same lack of capacity, same, yeah. They might use voluntary placements more than we do, but I don't know for sure.
I'm not specifically in child welfare, but I am in the social work school at UNR. From what I hear, it's a lack of staffing, a lack of if the feeling is do everything you can as a social worker to keep this having to be put on child welfare, and at that point, because there's just too many cases. So this might get taken and then it might just, a case may need to get built by more, it may need to come across, his case may need to come across a few times before something really happens. So the thinking is, get as much done without having without it having to get to that point of going into child welfare.
Well, let's move to the second vignette. This one will probably take less discussion, and then we can talk a little bit about kind of, you know, here's the as is scenario that we just talked about for both of these, and then talk about ways that maybe some of the tools that we discussed earlier could be deployed to address it. So, Angelica, could you move to the next slide? So this one, Ava is a 10-year-old female who does not want to return to school after summer break. Her parents are very upset with her and do not understand why she's creating a problem. Ava's mom works full-time at the gas station as a cashier, and Dad's disabled from a brain injury, leaving his memory significantly impaired. Ava shared that she's afraid to go back to school, and her heart thumps and beats fast whenever she thinks about school. When asked why she's afraid, she shared she doesn't know why. Her mom calls the doctor's office and school for help and is waiting for both to call back. So let's start in Washoe County this time, and ask how, you know, so say Ava's in Reno. How does this play out from there?
Hello?
Yes. Sorry, were you trying to weigh in?
No, I couldn't hear. You guys went totally blank. I was just making sure I was still online. Thank you. Sorry about that.
No worries.
Someone from Washoe School.
Is there anybody from Washoe Schools or? Or how could this play out? We'll allow for theorizing about Washoe for the moment.
Well, Washoe does have a pretty strong MTSS program, probably stronger than Clark County School District. So their ratios are slightly better than school-based personnel. So again, this is ideally, it doesn't mean that it will play out like this, but in an ideal way, that the school would, talk to the child and the parent together, really try to figure out what's going on, and then help reduce the anxiety to come back to school. Washoe is really strong in Tier 1, which is the social emotional learning components. And so incorporating some of the mindfulness and those kinds of things before coming to school, or whatever seems to meet your needs. But that would be the ideal solution, the ideal.
So it would be a school-based intervention?
It could be, yes.
And what about the doctor's office angle? What happens if she goes to the doctor's office?
Hi, this is Leanne from the American Academy of Pediatrics. Well, the doctor who pays attention to my newsletter would contact the PAL line, I hope, and get contacted with Dr. Lisa Durrett and get hooked up with the right interventions and services.
And so what is the line that you just mentioned?
So the PAL line is our doctor-to-doctor consultation line that a number of other states have, that was modeled after MCPAP in Massachusetts. So any physician in the state of Nevada seeing a kid who needs behavioral health interventions can contact the PAL line, can speak with a child psychiatrist or one of the fellows, and they get a call back within the day to get that doctor-to-doctor consult about what is the next step for this 10-year-old kid.
Sorry, and I should have said that probably Washoe would have also, tried to do some more handoffs as well, to go that route.
What about not the best case scenario? What if, what if the school district doesn't call back because they're understaffed? Or what if she gets a doc that isn't one of your docs, that's, maybe has no idea what the PAL line is, what happens then?
It goes ignored, she never goes to school, fast tracking her into some sort of delinquent act, and then she ends up down the delinquency system path.
That's a bad scenario.
That's the worst case scenario. That's what we're looking for. We're always looking for good.
So what's the worst case scenario? And she's pregnant at 14 and a half.
Right.
Well, and or educational neglect, and the parents pick up a case through the agency as well.
Well, that would be T-Pop, referral to T-Pop, your name, that's
So TPOP is Clark County's truancy prevention outreach program. It's run through the harbor. It's like an arm of the harbor. So I mean, ideally, again, I go back to the 5th largest school district. Every school would be aware of this program that's out there. I don't know that they are. I think it was only piloted in a few schools, and they would make a referral because this 10-year-old hasn't shown up for school. They would make a referral to the truancy prevention outreach program, and that would then get her on a track of engagement and services to get her into school. So possibly not worst case scenario, better case scenario.
This is, I don't know if everybody can hear me. This is Jennifer Bavacqua. I work with Eagle Quest, and we do operate the harbor.
Yep, there she is. That's the harbor.
Yep, we can hear you.
Yeah, Jen, we can hear you.
Okay, sorry. I think I'm following everything. Just another thought as a possibility is as a no wrong door, the harbor could be an entry for Ava and her family. One of the things when I saw Mom Works Full Time, I know that can be a barrier sometimes to getting into, meeting with the schools maybe initially. And so the harbor is open 7 days a week from 8 a.m. to 10 p.m. That sometimes can be helpful for families to access. They can come in on the weekend if needed. Again, we're not, we can solve everything, but we want to be a part of the solution and process. And I was just thinking too, for her and her family, even as a starting point, we do have a school district representative that also is connected to the harbor, works at one of the sites that could maybe also be an advocate or help to reach out to the specific school that Ava is zoned for, to be another voice to the counselor, or get it on their radar that we have a young lady who is, or a child who is struggling, and maybe and then the team could offer some other supports. Again, as you guys have talked about, we do refer. We utilize a lot of the same providers, but we do try to make sure that when we refer, someone's actually calling back, or the family is following up if needed for other support. And we can also do some things on site as needed, just to kind of help and work through, the resources that are out there for youth that are feeling a little anxious about going to school. Working with Nevada PEP, I know, Karen, you already spoke. And just, again, trying to be no wrong door and offering the supports that we can, and linking to, more intensive services if needed, if she's really struggling. And then as I think it was Bridget Duffy was talking about TPOP, sometimes that program is usually if youth is truant from school, I think the threshold is, 7 days, but maybe we could get them in earlier if we already know this child is at risk to miss. So thank you.
Jen, can I ask a quick question? This is Stacy from Nevada Medicaid. So I just want to make sure I'm understanding. Is the harbor statewide, or is it just Clark County, or is it a state service? I'm just trying to understand kind of where it lives.
Sure. It is in Clark County, and it is actually started with the Department of Juvenile Justice. However, as people mentioned before, it is not just to serve kids in the juvenile justice system. It is meant to be more of diversion, and as we have been in operation, more families learn about us, and they come in and have had no experience with the juvenile justice system, and that's great, because we like to let them never see it. But it is it was started by the Clark County Department of Juvenile Justice. There are some other partnering agencies, of course, and for the rural folks that were on the call too, they are talking about doing some like a rural harbor where you can go we can provide some services there and connecting out there as well. So I look forward to talking with the team on the system of care team out there as well,
great.
and NCRT.
Sorry, I have one more question. So just thinking through, you guys are, in my mind, and I will be honest, I'm not an expert in wraparound. Like, to me, it's like the different side of the system. I'm on the healthcare side. But sounds like that's what you're doing. Or do you ever have a situation where providers or physicians or healthcare providers, behavioral health, any of those folks are actually bringing you children and families and connecting those dots? Because it feels like to me, like, I'm not sure if the systems are working well together. And you know, are you here for managed care plans? Like, is there any type of healthcare coordination going on? And if not, like, is that something you would like to see? Because it feels like to me those two, if better connected, could be even better for the kids. I'm just trying to think through like what those scenarios might look like in my head, but I'm just curious if that's already happening.
Sure, we do. When families come, we do ask them to provide us if they have insurance already, because that helps us to link them with an appropriate provider from the list. For any of you working with providers, and Eagle Quest, if I put my other hat on, we have mental health services as well. So, you know, we are constantly changing like where our wait lists are for certain insurances, panels, that's the word, because, you know, you just have limited clinicians. So we try to keep track and keep updated from the different providers and what types of insurances they take. So we do ask families. And what we actually have started doing recently, I think we have one scheduled with Anthem this week and Molina, and Silver, I'm going to say it wrong. Anyway, we've been reaching out to all the insurance managed care providers and having them give kind of overviews of all the services they provide too as part of their benefits package, so to speak. I know some offer memberships and some offer this. And so really trying to get our team members even more educated. So when a family comes in and says they have Molina, for example, we also, it triggers like, oh, do you know they also offer this, and this? Just want to make sure you know all of the benefits you have in addition to you know, traditional therapy access and other services. So we're trying to keep, you know, ways to not be isolated, right? Like, you know, work together and utilize what resources are out there. So definitely open to more conversations, and as ideas you have, please share.
Well, just helpful. Yeah, I may be following up with you directly. I mean, it seems like you guys are a great resource for families, and just thinking through, you know, it is in the plan's interest to get the kids services and get them in school, right? Like, all those things are healthier kids. And so I'm trying to think through, like, making sure that connection's happening. And I'm glad to hear that already is, but I definitely will probably follow up with you and see how that's going.
Absolutely. Thank you.
So how would this play out if, you know, Ava's in, say, Wells or Mesquite or somewhere like that? You know, she's definitely going to be in fee for service. It's probably not going to be a crisis situation. What happens then? It sounds like the doctor might still know to call the PAL line. What does it look like for schools in more rural areas?
Like, I tell you, on the behavioral health side, they're going to have trouble finding a therapist and finding a psychiatrist in Mesquite, because there's very limited services there. And depending on if mom has a car, we saw them go to St. George and other places, but then you're across state lines and then you have eligibility issues. So some of them are coming into Vegas. So without telehealth, it's a huge barrier on the behavioral health side.
And Michelle's still online, but, you know, mobile crisis as well. And then we also have a rural mental health clinic system that could either do the service themselves or connect to a service of the, you know, service provider of choice via telehealth. I think one of the things rural Nevada fared better during the pandemic is that we're used, and I'm from rural Nevada, we're used to telehealth. This is like a way of life for us. So it wasn't a huge shift. And so in some ways, rural Nevada is set up for these kinds of things. You know, not everything can be done by telehealth. So that becomes the problem. Transportation becomes the big issue.
and I think too, just to piggyback off what Christy said, we have some amazing school social workers in our rural schools. So if we're looking at Wells, there's some great social workers in the Elko School District. I think, we would probably tap into them. And then again, the physicians here, we do have the pediatric access grant as well as the PAL line for physicians to be able to connect with us child psychiatrists to get some help and consultation. So again, I'm pointing out the good stuff. I'm not saying that rurals are perfect. We definitely need a lot of help, a lot of providers. We need workforce and everything. But just in this scenario for this youth, that's probably what I would have seen happening.
Okay, and then let's move on to kind of some of the discussion, and I think we've got some questions on the next slide. But thinking really about kind of future environment, and maybe thinking about some of the ways, thinking less about the best case, because it sounds like in the best case, kids do get served, but in the cases that aren't the best case, what would happen, and how would you, thinking about the non-best case, and I know many of you have seen non-best case, what are your thoughts about how you could improve the system of care to meet the needs of people who are not best case, who are falling through the cracks, or however you want to describe it?
So my question is, if you had therapists in the school, would that provide care right away, or maybe an obstacle? I just kind of go back to my experience having providers right in the school, need access, they have the skills to do that. They can meet with family. Would that be a benefit?
Yeah, I think the data pans that out. I mean, if you look at nationally, not even Nevada, 80% of the kids get their mental health services in schools because that's where they're at. So yes, and that's been our experience. When there are providers in schools, they get used. And it's really like you kind of heard today, right? It's kind of hit or miss, whether, sometimes the schools call it refer and pray, right? They don't know. They don't know if it's really going to happen. There's not a communication loop back from community to school to see if referral actually, occurred and the child's getting service and the whole 9 yards. So I think without some sort of system, we get really, spotty in our implementation. But in the schools act as that hub. Again, they do tier 1 and 2 services really well.
Sure.
And then the community providers really do what they kind of shine in that tier 3, that individual wraparound family care kind of thing.
Sure.
Working together, that's the ideal.
Right. Well, I'm guessing that there's a capacity for the providers to go be in schools.
Right.
Well, and I think too, and I know this probably just isn't in rural Nevada, but across the state, we need more providers that specialize in early childhood mental health.
And part of that goes back to where we began. I left and came back and still chatting. But I wrote it down at the very beginning, talking about data sharing. And that's a big key piece. And I know with the Harbor program, we have been trying for a really long time to get an MOU with the school district to be able to cycle that information in a big circle so that, one, the schools know what's happening, and two, the Harbor knows that it's actually working, so that we can see that if a child is referred from the school because of behaviors, whether they're just like our child in the vignette had, or if they're delinquent style behaviors, that the intervention is actually keeping that child from being suspended, expelled, or engaging that child better into school at all. But we're missing that data connection piece. And then on the reverse side, I see some of the cases that I've seen, I'm missing a data connection piece from mental health because of the HIPAA barrier, information going to the schools. So what I've seen is a lot of, some recently, delinquent behaviors that are occurring in schools, such as batteries and things like that, are children who just came out of an acute hospitalization. The school had no idea that child was just in the hospital for suicidal ideation or an attempt, within 24 hours before being dropped by the parent who needs a break into the school with, 1,000+ kids on campus. And so there's no communication to the school to handle the care, whatever that means, we have that somewhere. But to know that child's had that. So all of that data sharing around that child is important, but there's so many barriers, and we have to figure out how to break those down.
One bright spot, again, this is a bright spot, in the world, I don't know why I'm bragging on the world today, but hey, they're doing some good work, right? So we have districts with several MOUs with different providers and community organizations. Rural mental health, with St. Lyon County for one, they have a health hub, right? They all have MOUs together, and when the students come in, they actually sign the release of information around HERPA and PERPA. That's a mix of PERPA and HEPA. It's a new word. So I think, we have some bright spots that can be done, and that, if the harbor is considering that, that's an exciting next step, is to really go that next step again.
So replicate that.
Yeah.
Too many lawyers in the Clark County School District.
I think another thing too, so the, providers that specialize in early childhood mental health, and then also our peer support programs. I think those are both things that we could enhance to really help build our system. If that was the question, if that wasn't the question, then never mind, I'll save it.
Well, and it seems like we're still kind of focusing on, how things today can work well, right? But what about when it doesn't work well? And kind of getting more into thinking about problem solving, right? Like, say Ava gets in the situation where, the school doesn't call back. Or say Luke is in the situation where, the school notices it and tells grandma, and grandma says, stop it. And it escalates until he has an attempt. What would be ways that, that you could put in place things that would prevent those types of outcomes? Or after those outcomes have already occurred, make sure that child gets the treatment they need so they don't occur again or don't get worse.
So one of the things I think becomes the biggest barrier in our state are just the number of different players that are a part of that. So some sort of one-stop shop, neuron door, whatever you want to call it, where the family, the school, the whoever calls one number, and it can get them out to multiple agencies. And we see this all the time, even between kids that have been in child welfare for years. Like, they don't come into our service system until they're at a crisis point. When they could have been getting in-home services in their foster care settings, that kind of stuff to try to help that. But there's so many social workers, even in child welfare, or in other, there's so many different teachers, there's so many different, all that kind of stuff. It's just, it's hard to get to all of them. And although we're constantly trying to do outreach and constantly trying to be like, hey, we're here, we can help with kids, if they qualify for services, that kind of stuff, it's not possible for us to constantly reach every single person. So people fall through the gaps.
I was going to say, I think about it, we still act like we're a really small state, and our systems are very relational. So while you're seeing that relational works in our rurals, right, because they're small, it's not working anymore for Clark commercial. So we really need systems in place, like the MOUs, so that we can, but sometimes we focus on the practices instead of building our actual systems. And so I think, a glimmer of hope for us is to actually look at that system and how do we mutually reinforce each other. So
coming full circle back to some kind of governance and interagency MOU around children and families, and what does that look like, and what are the triggers, and I think it's bringing us back almost full circle.
Well, it addresses your question about data collection as well. You have that structure, so we get across and communicate.
So I'll tell you, figuring out the FERPA, HIPAA, what did the CFR, domestic violence, protections, like all the statutes, because you probably do pre-K,
who do children with behavioral health needs. You have some kind of school health program that DHHS is supporting. You have after-school time activities that are happening in schools that pull in the Y and other partner agencies, where they're also dealing with some of the social emotional well-being needs of students. You have probably, community schools, right? Child protective services. Think about all the different intersects between schools and all the providers of social emotional well-being needs of children. And so when you think about if DHHS was that parent organization with whom you wanted to set up that MOU, you'd have to think through all of those, right? Pregnant and parenting teams, for getting services, all of that. And you'd have to think through. And so your attorney general or your assistant attorney generals for school and for DHHS is going to have to get to be very creative and supportive of the outcome that you're setting for yourself. That's often where the challenge is they're much more protective of data sharing than otherwise. So if the folks who are lawyers in the room can persuade but if you think, but there has to be something there. We went to our client, to our county attorney. It took me 12 years, don't get me wrong. It took me 12 years to get it worked out with the school system, but we had it, right? For what we called early warning indicators for students, that was the language that schools used. And we said, if these EWIs were present and these were the service cluster, then we would share information with these outcomes in mind. And we went to our attorney, school system attorney, and our attorney, and we said, we're your clients. This is the goal we want to get to. Now help us figure out how to get there. We're not telling you this is how we want to do it, because the way we probably want to do it is the wrong way anyway. We don't anybody want to go to jail, but you tell us what's the legally sufficient way to get us there. And they did. They worked. It took a while, but we got there. It's doable. But it's hard. The other way is just do it and then ask for forgiveness later. There's always that way, right? But
playing devil's advocate, were there children's attorneys involved? Because the children have certain privacy rights and all this too. So that's what I'm saying.
We did. We had the American Bar Association Children's Rights folks, Kathleen McNaught, Kathleen was part of that whole design. And most of it was de-identified information, right? But if you only have 6 kids pregnant in a school, and there are 9 kids pregnant in that school the next year, even if it's de-identified, you know who you're talking about. So there are some very interesting, it's challenging to get this right. I'm not trying to make, as I said, it took me 12 years, but we got there because we kept at it, and we kept at it. There was a lot of trust, because we worked with each other all the time, right? We knew each other. So we got there, but it takes a while.
So could you tell us how we can get there?
I can get you drafts.
Yeah, I'm thinking you share the language.
We could share the drafts, but but attorney to attorney, jurisdiction to jurisdiction, I don't know that you sort of still have to, it's not like HIPAA and what did you see apart.
Still helps. I mean, some attorneys are like, it's black and white, we're not doing that. But I think if you can show that another state figured it out, then it does help change.
The other place that's done it really well is Allegheny County, Pittsburgh. They have done a brilliant job. Pittsburgh DHHS, Department of Human Services, Allegheny County, and Pittsburgh Public Schools. They've figured it out. They share information. And they do upstream, right? So they determine based on profile, is this family at risk? And they offer services and voluntarily get there early. And they've built all these family support centers throughout their community so that parents can actually go to those neighborhood family support centers and ask for help. And you can build your school-based health centers in the same way, right? They're all in the neighborhood. Schools are in communities. Schools are in neighborhoods.
The Harvard of me seems like now it is kind of what we used to have our family resource centers in the community. It's kind of becoming that one-stop shop family resource center.
Yeah.
And I know they've looked at Allegheny County when they were just for some of the.
They're best of breed, they're running, right, for sure, best of breed.
Well, and family resource centers are also that wraparound piece for, rural.
And I think that's, you know, the information sharing for sure is one piece of it that needs to be addressed. But what are other pieces that come to mind? I mean, you know, we know today that best practice doesn't always happen, right? Like Luke or Eva might end up being one of the kids at Shelby. And, you know, how do we keep them from getting?
I don't think we all know enough about the services that have evolved. I mean, I think many of us may know the name of a program. That program has gone about 4 or 5 iterations since we first heard their names. And so what do they do now? How does it pertain to the kids that come into our care? Having that kind of information that is up to date, because it changes. And so by the time you get something printed, it's gone. So electronic information can be wonderful now because it is so easy to update things, but we have to take the time to do that and then distribute it to everybody. Particularly our schools. I feel like our schools are probably the people who need to know the most, and they're probably so busy all the time they can't get outside their own doors. It's my own experience. And I think they're all trying to do the right thing, but we're secondary to their doing the right thing, which is education. And so we have to help them know what's available and how to use it. What are the access points for my program, for someone else's program? How do they even know where to begin? And I feel like they don't know.
Is there Medicaid services, or is it more kind of just in a general sense?
I think before you get to Medicaid, it's great to know the community services. And so sometimes we need Medicaid, like the 15-year-old. Maybe we wouldn't have needed that if we got them connected to a family support program that's in the neighborhood or at a church or something like that. So knowing what exists and how to get people to those doors with a warm handoff, that's the key. Because I find engagement, we may have all the things we think we need, but that warm handoff is critical, I think, to being active.
What if without a 2-on-1, is it a resource? Does it work?
So you said that, and so now I'm embarrassed because I should know, right? I mean, really. So if I'm not, so maybe I need to know.
I mean, Nevada 211, you can call 211, you can look it up, Nevada 211, and you can search it, you can tell them whatever resource that you're looking for, statewide now. But I mean, that's because as soon as you print out a resource, it's already out of date. So I think sometimes too, we have to not forget that we do have some resources available to us. Are we utilizing them? Do our schools know what's in there? I mean, 988 is now coming out, which is the mental health piece of that. And so I also think that we have a lot of resources, but I don't know that we share them enough and that we use them enough. And then just that study next to service delivery piece of it, I think is always it's a challenge, you know.
But I think there are a lot of services that we don't have, right?
Yeah,
And so you can, how do you refer, referrals are only as good as what you can be referred to, and if the service doesn't exist, or if it has a 2-year waiting list, it's not helpful.
I think funding, I think your original question, I think the sustainable funding has been a challenge because we might find a program that works or something that is useful when the funding dries up. The organization has to change their focus because they've got to follow the money. And so it is really hard to start to get sustainable or long-term programs where here's how to access what here's what we need. I mean, and to Kim's point, we staff really high need cases once a week, and we don't walk out of those meetings with, oh, I have 19 new ideas. It's okay, I guess we're still waiting. I guess it's going to be another week. I guess it's going to be another week, right? Because there's one option, and that one option just had somebody quit. So now we just, oh, it's gonna take 6 weeks to hire somebody, or, right? Because there aren't a lot of resources for those kind of kids. I think we have plenty of people who can do a 15-minute or 50-minute, therapy hour if somebody just needs outpatient counseling. But it's when you start to get to more higher needs or more specialized services that are needed, then we really start to run into, well, there's one guy that does that.
And even some of the lower, kind of more ancillary, right? We don't have enough respite. We don't have enough like intensive in-home and those kinds of supports. The wraparound, the care coordination, all of that stuff is part of our model that we have very little of it. And so I think we have that, and like you said, then we have the 1 hour, and then we have you go live at a hospital. We have very little in between, and thank goodness we now have. I think we're up to 2 PHP programs in Clark County, 1 in intensive outpatient for adolescents in Clark County. But I mean, these are all gaps that have to be filled if we want to keep the kids out of the higher level of care.
What about care coordination? You mentioned that, and I keep thinking about that. Like, where are the care coordinators? And is nobody referring to a care coordinator? What does that look like?
I guess that I've been just sitting here thinking, and I spend a lot of time in my own head, and it's a dangerous place mostly. I think the frustrating thing for me is we all admire the problem. We all spin around in our cases that we review once a week, and we all admire the problem. But when it comes down to it, there's nowhere to refer these youth to. There's not a robust network of providers at the appropriate levels to refer them to. And at some point, we've got to move past admiring the problem and figuring out how to incentivize and stand up the right providers in the right places and keep them there. Like Jill was saying, I can hop online and get a 50-minute therapy session, right? I mean, that's probably not a big gap. But the far end of the spectrum of the acuity of youth with ID, ADD, aggressive behaviors, autism, alcohol and drug abuse and use, and all those things, that they just sit there and spin. They spin from Child Haven to the ER to maybe a PRTF till they get booted out of that and dumped back at the ER, and they just spin and spin and spin and spin and spin. And I don't know, I guess the whole conversation to me is frustrating because I tend to be more of a person of action, and I feel like we're just admiring the problem. Little Ava, there's nowhere to send little Ava, so why don't we deal with that instead of trying to brainstorm maybe something we really didn't know that you didn't know that maybe you did and you didn't. I mean, there's not. We don't have a robust network. We don't have that. I mean, that's what we need to get to yes on, is how to build a robust network, incentivize providers to want to come to Nevada to work and play and do business. And then once we get them here, we need to figure out how to keep them here. So I feel like I can talk about all day long if Ava is being bullied at school, maybe that's why she doesn't want to go back or whatever, but she doesn't have anybody to screen Ava, right? So I don't know, I feel like I'm to the point where we've got to take a step forward and figure out how to stand up programs that actually see more of these youth. I mean, we know what we have, and we know what we don't have, so now we need to get more of what we don't have. That's how I would break it down in my mind.
Andrew Larkin says you hit it on the head, hit the nail on the head.
I don't know, I guess I'm just getting frustrated with the conversation right now.
But I think that goes back to Jill's question earlier. If you build it, will they come, or do we have to build it first and then figure out how to pay for it? And my worry is with how broken and disjointed and lacking the system is, I don't think we can just trust that they'll come, right? Like, and so there are things we have to to build up, and then we have to figure out how to pay for building those up and get it going.
And we need a little bit of both.
At the same time,
Right,
yeah.
you have
to do both.
Yeah.
You have to infuse some money in the
Right.
system, you have to rethink how you deliver paper care, or you're not gonna have this infusion sustainable, it will not be.
Right.
I mean, the program is growing, our Medicaid program is huge now, like 1/3 of the state is covered. It's just a big program.
I'm hearing both, there's some commonalities even both of what you're saying though. It's like, it's kind of like you're doing this without a path. You fall
Yeah,
and
there is, yeah, but if we don't become people of action together, and New Mexico does, then they're gonna go there. So there's not enough of them to go around. We need them, and we need to put ourselves in a position of partnering with them, the them that they are, so they don't end up in another state or graduating with their PhD in therapy and moving to Chicago because the job market is better and the reimbursement rates are better. I mean, it's the egg, the chicken, the egg, but meanwhile, the youth just are still spinning at Child Haven and the ER.
But there are some things in the education world, higher ed, that are not at this table that can be done to help our medical students. I mean, there are things states can do to incentivize students to stay in the state. So I mean, I think that's someone who's not at this table, but it can't all be on all of us. I mean, it has to be in the whole state. I just wanted to say, I agree, I think the workforce is key. So we need school-based, because school-based, what we saw with other states, increasing school-based ratios, is that they work more closely with the community, right? They don't have like 4,000 to 1 social workers to kids. So when you have more time, when you have a better ratio, then you have, so it's both. We need more school-based providers and we need more community-based providers. And I just wanted to add one more thing. We're sitting on an amazing resource that we were talking about at lunch today. So Clark County has one of the most diverse student populations in this nation. 109 languages spoken right in the schools. And they are so fluent in their own mental health. If we can get those kids into our workforce, it will change Nevada. I mean, I don't know if you guys have met this new generation, but they're incredible. You guys should meet them. They will help us, but we have to set up this system to get them from our high school, from our elementary school, high school, into our ancient system in the mental health field. And you will naturally diversify the workforce. They speak different languages. They're an amazing group of kids. We want them. We want them to stay right here.
We want them, but the broader community has to see the value.
The economic opportunity.
Yeah.
Yeah, and I think that's a big problem.
And we need to make Nevada a place that they want to stay and work, as opposed to being, that's what I'm trying to use, coaxed to other places to relocate, So, yeah, I mean.
Don't, again, I would say, don't take on everything all at once. It'll be a self-defeating proposition. Pick the issues that you have the most control over in the short term. I agree, like you can only examine your belly button so much. At some point, you gotta say, okay, this is what it looks like. Let's go figure out what else we're gonna do. And so you are in a moment where you're saying we want to do something different. You've identified, I mean, you've used these two cases to sort of say some things work, some things don't work. That's okay. Like that's kind of how it's not like your state has nothing. It's got things that they're just not working to the top of their capabilities. There are some gaps. Okay, what are we then? First, I still think it's a state, you gotta get the state partners together and figure out sort of what it is. Then you gotta figure out, you gotta bring the counties into the mix, you gotta bring the providers into the mix, and at all times keeping kids and families in the center. So use that kind of iterative approach and start widening your circles and figure out what it is. Because if you do everything, you just don't have you're tired, you're working hard, people are exhausted. I mean, every time we have this conversation, everybody, like, it's hard. It's hard work. People don't appreciate how hard government works. They don't know how hard you guys work. So, we get it. So, policy on the money is here right now, so you gotta start there. And then keep growing that circle. That's-
So, I think on that note, we're out of break time. But I think I think this is a really good start to a discussion. I mean, one, I think it's really good that you're kind of opening up and saying, here's what, we're tired of waiting, right? I think some positive comes out of frustration. So, let's pause, we'll take a break. And then we'll come back, we've got some more about Medicaid finance, your favorite topic. I'll try and not put you all to sleep, but it's relevant and it's important because money is important. I think Stacy can tell you and Suzanne would tell you and Cindy would tell you that money is not something you just go get. It's from, so we'll talk about that and then we'll come to the end, and then that brings us to the end of the agenda and we'll talk about next steps. And moving forward to something that's more than just kind of today, we're, like Emma was saying earlier, we're presenting information, we're getting discussion started. This is really just kind of, helping give you some thoughts and tools how to frame the problem. But then from here, we move to, we have to go into open meetings, we have to go into the structure that the state requires to really start solving the problem and making recommendations. All right, so we'll go on break for 10, 15 minutes and then come back. So Nevada's been working on this crisis response continuum since before the pandemic. You know, we've all talked about this. The needs have only grown during the pandemic. Got more funding under Arpa, under the Rescue Plan Act, and the department recently requested and received approval for $126 million. But those are temporary funds, and they turn into a pumpkin after 2 years. So this is a really important topic. Next one. So, and in the discussions and the presentations, I'm sure most of you have listened to at least part of it, that it's anticipated that Medicaid funding is going to be taking over, and it's going to be a sustainment strategy. So, you know, we all know foster kids are universally eligible for Medicaid. Nearly all the kids involved with juvenile justice are eligible for Medicaid, and many of the services being implemented can be covered as Medicaid benefits. But there's not a state income tax, there's limited revenue sources, flat budget, you know, we've talked about this a little bit, unless there's new appropriations. So that means you have to think about ways to make sure this can be sustainable, or at the very least, if you're going to ask for new money, that you're able to go and say, yeah, we're asking for new money, but we've taken some steps to make sure that we've got some sustainability built in, and that we're taking advantage of all the opportunities that are out there to leverage state general funds. Next slide. Some of this, so these are all the Nevada efforts. This kind of gives you the breakdown. You might have seen this before. You can look at this on the slides. I'm not going to go through them. It's, you know, it's big. It's great big numbers, hundreds of millions, or over $100 million. And we've heard some discussion about some of these today. You know, 14 million for wraparound and so on. Next slide. So just sort of this is sort of the Medicaid 101, right? So Medicaid, you can kind of think of it as public health insurance, but it's an entitlement program. It's cooperatively funded by the federal government and the state of Nevada. And so Nevada makes the commitment of, we're going to cover these services, we're going to cover these populations, and they take on risk when they do that, because you're kind of writing a blank check in a sense. If you're covering those services, and those services cost $100 million, and that's what you anticipated, then that's great. But if those services cost $150 million, you still got to cover those services. It's not a grant program. It's not a block grant. It's not anything like that. So, and every state has their own match rate. That's based on a national funding formula, and you can move up or down every year depending on that match rate. You know, some years you're like, oh, it moved up by 0.23%, and you're like, yay, everything worked out for us this year. Other years, it can move down, and you're like, oh, we're on the hook for an extra 10, 20, $30 million in state general funds. And we've got to go ask for that now. And that can be really challenging depending on the budget you're in, and depending on, you know, how your governor's office or your legislature is looking at it. Right now, Nevada's at 63%, so you've got to come up with 37% in state general funds or other local funds or some other method to fund it. You can kind of think about it another way. Every dollar you put into Medicaid, you get $1.68 out from the federal government. And then you get a higher CHIP match for kids that are on the CHIP program. That's true of every state, you know. But this federal matching, it kind of depends on how you're doing relative to everywhere else. So, you know, if Nevada's doing pretty well economically, then that means your match rate drops. If Nevada's doing really poorly economically, then not bad, but at least your match rate goes up. And that's all relative to, you know, Idaho and Montana and Utah and wherever else you want to look at. The costs to administer the Medicaid program are at the general FF rate. So that's 50%. So you know, like everybody's salary on the Medicaid program, generally speaking, is 50-50 federal state funds. If you're the Medicaid, or the medical director or someone like that, you get a higher match. But yeah, and there's maybe a few other things here and there. There's like this whole long list of stuff, but generally it's 50-50. And then some specific populations and benefits and expenses get higher match. So Indian Health Service or Indian Health Clinics are a good example. They're 100% federally matched. Family planning, 90% match. Medicaid expansion, 90% match. There's a whole bunch of different examples of higher matches. And then you budget according to the cost of your program, you know, kind of thinking about it in a simple way, the number of enrollees, the cost per member per month, and then you add on whatever your administrative costs are on top of that. If you're going to increase rates, if you're going to add populations, anything you're going to do, you've got to go to the legislature, you've got to ask for the money. And they've got to approve the appropriation here on a biennium, which makes it a little bit harder because, you know, you're looking at 2 years instead of 1. There's a few other states that do bienniums, and you know, but it's never an easy thing. You also have to ensure that you've got adequate administrative support and capacity to do all this in accordance with federal requirements. And states seem to be continually learning this lesson, that they'll underfund their Medicaid program. People will do the best they can with what they've got. You know, you'll have this very small but mighty staff trying to do really big things. And at some point, you cut enough corners that the OIG comes and audits you and says, state, you need to pay us back X $100 million. You know, so this is
like our worst nightmare.
I know, I'm sorry to bring up your nightmares.
Yeah, we're having moments here.
But it's a true story. You know, go ask New York about their school-based service program, and they'll scowl at you. Anyway, next slide. So these are the ARPA funded efforts, and we've just taken a preliminary look at this, but you know, looking at these, it looks like these ARPA funded efforts look like they can be sustained as Medicaid benefits, right? Wraparound, certainly. There are plenty of states that do wraparound funding. Day treatment, yes. Supported living for children with IDD, yes. You know, there are lots of different ways that you can support a lot of these investments going forward with Medicaid funding. And so these are the ones that look like they can be sustained with under Medicaid benefit funding at that 63% federal match. So here's one avenue going forward that, you know, you could be able to sustain these. Next slide.
With new state, like appropriation.
Exactly.
Sorry, I'm a broken record on
Good.
that, but
No,
like
no,
our program right now couldn't, unfortunately.
Yeah,
like,
no, it's not like there's
Yeah.
money laying around
Yeah.
to say, oh, we'll just do this. You do need to get the state general fund appropriation. And then the ones that are kind of outlined in green, you could probably get 85% federal match for 3 years under crisis funding. So that, you know, the mobile crisis, the intensive in-home stabilization services, those look like they fit under the, you know, the funding stream established under ARPA for 3 years, so you could get that enhanced federal funding. So that helps. Next slide.
So Matt, was there any enhanced for respite, or is that a straight match?
That's a straight match. The other thing that has some enhanced funding activities, I mentioned this earlier in the day, health homes for behavioral health. So these go all the way back to the Affordable Care Act. They changed, I think they were 80 and now they're 90. 90% federal match is available for 8 quarters. So you can get 2 years of enhanced federal funding. And they allow for some flexible payment approaches. Like you can do a provider capitated rate. So you can say providers, you know, here's your PM for providing these services, either partially or otherwise. And they cover a lot of services that aren't typically covered by Medicaid. Things like comprehensive, and you know, if you look at the little wheel thing up here, comprehensive care management is part of it, health promotion and wellness, patient and family supports, transitional care, importantly, care coordination, and then referrals to community and social services. Some states use that for, and there's quite a few, Minnesota, Arizona, Connecticut, they're all over the map, right? Fee-for-service, mixed fee-for-service and managed care, solely managed care. And you do, and so this is a good option for tapping into some enhanced federal funding. However, it's not without strings attached. There's some, you do need to measure quality metrics. There's actually like a health home state plan amendment is the only thing that's, I think, worse than a health home state plan amendment is a 1959 state plan amendment. They're not easy for states to pull together. Yes.
So this is a one-on-one question. You used this phrase before, and I kind of pretended like I knew what you're talking about, but now that you're talking about it, I kind of want to make sure I understand. So what exactly is a health home for behavioral health? Can you kind of spell that out?
Thank you. Yes. So it's you can kind of think of it, it's kind of analogous to the CCDHCs in some ways, right? But it's like a place where you get all this care coordination for a person with a defined condition. And it has to be a chronic, so chronic disease, like serious emotional disturbance will qualify, mental health, serious mental illness, those types of things. You can do a health home, not just for behavioral health, but for other conditions. But what we're talking about here is behavioral health conditions. And so it would be, a behavioral health provider that provides all of these services that are listed on the little wheel there for somebody who is being seen. So you can get fairly comprehensive care for someone at a behavioral health home.
But it's not a home, because you have all this coming from child welfare, so I just want to make sure, like, it's not a home, it's a,
Yeah.
it's a benefit. It's a benefit, okay.
So I would just add, in Minnesota, we created one of these when I was there, and the nice thing about it is a lot of behavioral health providers are in primary care are already doing these services for this population, and they paid for it. This not only pays for it, but also encourages more and more providers to really coordinate services and try to be more comprehensive for children or whatever your population is in their chronic condition. Like diabetes is one, but like this is really focused on behavioral health. And if you want to focus only on children, that would be, you can also what's really also cool about it is you can pay providers per member per month. So you can give them upfront payment where it helps on their cash flow. We all know that's a problem with the smaller rural providers or especially behavioral health providers. And if they do well within that cap, they get more money, right? It's like a win-win, or it can be also a loss. But the state, there's just different ways you can pay, which I think is so nice compared to the fee-for-service model, where we know sometimes behavioral health providers struggle with that model. It's not enough money, the cash flow, they're having issues with your business model. So I think the health home is just an interesting way of getting at not only these comprehensive services, but a comprehensive payment model in a different way for these providers. But it's a benefit, kind of like, physical therapy is a benefit. This is a new benefit. Does that make more sense? Yeah.
It says you could plot these in different locations too.
Yes,
We had a whole bunch of folks that signed up.
Yeah, you can
Clinic
limit
provider,
it.
it's like met the requirements.
It doesn't have to be statewide, unlike most state plan benefits, and you can limit by population. Yeah, it's an interesting, and it's 90% match, so it's a lot cheaper for a state to fund it, at least for the first 2 years, 8 quarters, and I'm doing the math right in my head. Yeah, so it's a lot, in some ways, it's easier to get started at infrastructure building.
And you kind of think about it like patient-centered medical home, which is sort of how it started, but they want to help homes because it's broader than medical, right? In fact, people have used it for IDD services. There's a couple, 3 states that are using it for IDD services, and that's a really interesting model too. Next slide. Want to mention this, you can also, and I brought it up earlier, Philly might have something to say about this too, but you can cover through local government entities, through intergovernmental transfers. So like, kind of like a collaborative arrangement with Clark County, for example, or with another county government. You can do the same thing with local education agencies, like the IDEA services, right? So for kids on an IEP, you can cover their costs by leveraging district funds, for example. And then you can do that as an intergovernmental transfer, or you can do a certified public expenditure. There's guardrails around both of these. There's pretty stringent guardrails in some cases around both of these, because you don't want to get in trouble with misusing the funds. Next slide. And that kind of gets us to the end of Medicaid funding. That's kind of just a start to it. The things to be thinking about if you can leverage the federal funding, it helps a lot when you go to the legislature. It's not, you know, if your legislature, you think your legislature is kind of a little like my legislature, there are those that are like, well, it's federal funding and it's coming out of somebody's pocket. We want to limit federal funding to, yes, you know, get all the fiscal responsibility arguments, and yes, you know, those are real. But it makes a difference when it's your own state taxpayer dollars versus whether it's federal taxpayer dollars. It just does. So anyway, that gets us to the end of this. That was actually pretty brief for Medicaid funding. So, and I didn't even put anybody to sleep. So yay.
There's a quiz. There's a quiz.
Actually, the quiz is one question. Which is better to spend, federal dollars or general fund dollars? Anyway, I will hand it for the next step section. I'm going to hand it to you, Stacy, to talk a little bit about this. Okay. I hope Suzanne had a chance to say.
I didn't know that.
I talked to Suzanne about it.
Of course, she didn't tell me. It's fine.
No, it's fine.
We did talk about it.
Yeah. And I can talk about this too a little bit, but
yeah.
I think I would probably not put it as well as folks from the state. Okay. So, next steps, follow-up meetings, survey, etc.
Yeah, so I think what we were thinking is having a few more follow-up stakeholder meetings, mostly by doing the virtual because it's easier and always cheaper for all of us to kind of gather, but doing open to the public. So obviously we have to meet open meeting laws, and we want to make sure that once we start talking about recommendations and solutions that we're complying with those laws, and also that we're including more voices, you know, getting all the public input we can. But I think, you know, in this discussion afterwards, if you know, not right after if you don't have time, but maybe following up, you know, about the kind of things you want to hear in the next few meetings would be helpful before we develop the agenda. I think in our head, we kind of know what, you know, we're thinking next in terms of like, here's our structure, here's some of the ideas that are on the table, and getting feedback. If there are other things you want to hear and learn about, please let us know. And then we also are going to do a public survey. And this will go out over our listserv to everyone in Medicaid, which will really be laying out some of these options and getting public feedback about what kind of strategies and solutions, at least on the Medicaid side, can we think through together. And then taking all of those options. And then we also have a lot of external advisory groups. There's a Medicaid Consumer Advisory Group. There's the Behavioral Health Consortium. There's several different groups our agency has. And we're going to take some of these ideas to them and get some feedback, prioritization. Obviously, those are open meetings, so anyone can participate and also provide public comment. And using that feedback, we're going to try to prioritize and put together a report that will post online to say, here are some of the options, here's what we heard, here's what we think might work, that kind of thing. And kind of also ask for public feedback before we finalize. And then the last step, last but not least, is taking it to the governor's office and director's office to say, here's what we found, here are the different options, here's probably the fiscal impact, but there's also maybe the value that we might see. It's a long road. I don't think that's all going to happen in a couple weeks, but we're hopeful by the end of the year to have most of this done. I'll stop there. Nina, did I get excited?
In addition?
Yeah.
In like 2.5 months?
Yeah, you guys wanted it fast, right? We put in our budget a request for anything that we identify, so we need to move quickly because the session's coming.
Yes.
So we want to make the most of that opportunity, otherwise we'll miss that window.
Oh my God, look at the excitement in the room.
Excitement? I don't know, yeah.
Such excitement.
I'm in.
Yeah.
I think that's what I'm sitting down. Right.
Oh, I do have a question. So when we get into the detail, like, will you help us like determine what would be the best waiver or route to go?
Yeah, the pathway there is I mean, if you're doing like a specialty plan, let's say that's it's a waiver, like a choice waiver. There's different things like that, a pathway.
We could get to that detail and
Yeah.
help us out.
So I think what we heard today, and I mean, I'm not going to repeat everything I think Ken and others were saying, but more information about how these solution options have, you know, worked in other states and not worked, right? What are the trade-offs, what are the benefits, a little bit more of that. I think also the vision statement is something we heard loud and clear. I apologize I didn't say that already. I think at the next meeting, that would be one of the things we would bring, like, here's what this, you know, some other states have put together, here's what we're thinking, it's from a Nevada tailored perspective. What are your thoughts? Help us frame this and come to some agreement on what our vision is. And then using that to really say, these solutions
each, each one can differently fit into our vision and which one makes the most sense based on the trade-offs and the benefits, right? So some of what you were talking about earlier, Jill and Pam and others, I think that would be the goal for the next few meetings. But obviously open to feedback and things that might make that conversation easier, information that we can try to get, just letting us know ahead of time would be helpful.
Are these slides something you can share?
Yeah, they're going to be on our website too. Afterwards, we did make a new page, or I think not even a new page, just like a new section on children's behavioral health. And it's also going to be an email box. So if folks have questions or comments, they can email directly on these issues as we're working with stakeholders. So we'll definitely send that link out to everyone so you can access the slides. And if you want to send us questions or ideas for the next few meetings or concerns, feel free to send them over using that as well. Or just email us directly too. Matt, is there anything else you'd add to that?
I kind of want to come back to the vision discussion and just kind of see if we can, if that works for you. But I think, that seems to be something that people attack as like one of the most important pieces to call out here. Because, if we come forward with recommendations, but we don't know what the vision is or what problem we're trying to solve or what we're trying to improve, that's probably not a good place to be. So I would suggest, kind of as an outsider looking in, that might be the next area of focus. But what do you all think? Again, a few cautious nods. What about the people who aren't nodding, either on the phone or on the virtual meeting or otherwise?
Matt, do we want to go back to that slide from North Carolina and their vision, just to have some ideas?
Yeah, I think that's a good idea. That one's, Angelica, that's like way up at the top.
Like number 8 or 9?
Yeah.
30 something.
So it's about developing a shared vision, is that? Okay.
This is where your governance is.
Yes.
Where'd it go?
It's like in the first 10, I think, or 12. Scroll down.
Oh, it's 28, I think, is the North Carolina one.
Right there.
There we
That's
go.
it. Yep.
Not to say this has to be ours, but it's maybe just starting some conversation maybe about it. But did we say this is what they used around this work to kind of drive?
Yeah. Kind of, looking at some guiding principles. I think too, kind of keeping the focus too on, because, we're looking to what's going to happen in the next biennium, right? So thinking ahead like 2, maybe 3 years, rather than saying, let's set our course for the next 10 years or 5 years or whatever. Thinking about, certainly thinking long term, but thinking about what would set us up long term within the next couple of years.
So those seem like priorities, not vision.
I guess for me, I was thinking something along the lines of, if I were to frame it in my mind, timely access to the appropriate level of care for the appropriate length of time. So I kind of went a different place in my mind than that.
It's totally fine, right? Like, we're just saying, this is what they use to bring everybody together and to anchor their work. You all can think about what makes the most sense for North Carolina, but I think it makes sense to have a straw man for reaction as opposed to, again, getting into a large group, and you can't create in a group of 50, right? So I think a straw man would be super helpful for the next conversation that everyone can react to. But then you're almost turning it into a charter document of some sort that all the anchoring organizations are signing. So you're making a commitment to using that as the framework, right, around which we're co-creating together. Like there are certain, that would not be this, it would almost be like
chartering document that organizations sign to say, we're in this together, this is what we're going to do, these are the roles, and central to that will be any kind of creative activity, like there's a co-creation component to it, that you're checking in with your partners to see what are the implications. If we went down this path, what are the implications for the other partners, and are there ways in which you can support this? Does this create barriers to what you are trying to do? So it almost forces that shared collaborative creation. It takes a lot of discipline to stay there though, and a lot of trust. You're gonna have to trust, because you like every other place, we have a lot of baggage too. Everybody has baggage. Those tapes start running and you sort of have to pause that tape and say, no, we're not gonna go down that path, but we've agreed that we're gonna do it this way. So we're not gonna assume the worst, we're gonna assume the best.
This is Karen. So we're on our 4th system of care grant here in Nevada, and we've worked hard to develop a system of care vision and mission, and I don't know why we wouldn't start with that. We don't have to start with a blank piece of paper, I don't think. And I think we should honor the previous work that's been done.
Kind of maybe look to narrowing it from there. Michael just put in the chat the system of care, what is it? System of care known for exceptional standards, chosen for excellence in service, and standing in partnership with community, children, families, and employers to improve the emotional, physical, and social well-being of all communities served. Right? Which is, I think, a great statement. But how do you narrow it from there to
That's very
here's what we want to do to move from where we are today to where we want to be in 2-3 years?
The other, besides a vision, it'd be nice to have some shared indicators, like how do we know we're gonna be successful?
That's your access point.
Yeah, what is Department of Education, what is Medicaid, what is UCFS? So we really have those shared indicators so we can really track them.
Yeah.
Which I think kind of gets to what you were saying about, what does success look like? What do we, how do we know that we're succeeding, and kind of looking to the models that we're picking and saying, well, they were successful in whatever it is, right? Reducing psychotropic utilization by 20%. I don't know, leaving this up, but whatever it happens to be.
Reducing wait lists, that would be awesome.
Access is important.
Yeah, we almost need like mission, goals, and indicators, and have a dashboard that shows like how we're doing. I feel like it's a lot more than just your vision. It's like also the goals that fall under indicators, all those pieces.
You won't get by if you only have those 3 sentences.
Yes.
But we want this to be brilliant. You can put all the best things and no halfway.
And then I think too, along with those indicators, like have the roles. Like schools don't have to do it all because TCFS is going to put mobile crisis teams in the schools or whatever, that they're each like
everyone
staying
owns their part
exactly.
of the
We know
system.
how to work together.
I think if you could get all the agencies to get there, then the next year, and then the next year, you keep fighting the circle, you're gonna get there. And then it wouldn't feel like, okay, we're just examining the problem again. It's a nice place to stop.
Yeah.
Right? It's a nice place to pause it for the day. Guess what, right?
And you didn't expect, I did not expect to get through all those slides.
I know.
We still have a half hour.
Matt and I talked about that, we said 75 slides.
Yeah, we had a mitigation plan and everything.
Yes, we sure did. If we didn't get through them, this is what we're going to do today.
Well, thank you all for coming today and spending your day with everyone. And I know it's a lot, and we're all in the same room. And those of you online, thank you. And more to come, for sure.
Any last words? Any last words of wisdom? Anybody has something burning? Too quiet. Okay, now like we're said, okay, we're ending, everyone's like, okay, let us go. Let us go, don't talk.
Thank you.
Thanks, everyone.